So welcome everybody to this session. We have the huge privilege of bringing together many different frontline health workers who, in different parts of the world and different types of roles, will be sharing with us some of their experiences around COVID-19. So we have experiences being shared from Nepal, from Kenya, Liberia, Oslo, UK, and another set of experiences from Kenya. And we have experiences from people who are frontline research staff, nurses in intensive care, researchers, trainers. So we're very privileged to be in a position to hear from these different people. In our session today, we have an overall goal of having an opportunity to hear from one another and to share resources, and also to just be introduced to a website called Connect, which is part of the Global Health Network, where we'll be able to continue our interactions and sharing more experiences. We'll only be able to really scratch the surface today, and it might well be that we will want to organize another session like this in future. So the way that this session will work, it's an hour and a half long, and we're going to begin with 3 speakers talking about working within COVID times in different places. We'll then have a question and discussion session where we pose questions raised by each of these 3 speakers. We'll then have a second session where 3 people give us some of their perspectives on supporting teams and being prepared in times of crisis like COVID. And we'll be hearing especially about a training approach called the iCare Halland model and how this has been implemented in different contexts. We'll then finish with another question and discussion session at the end, and an introduction in a little bit more detail to the website that I mentioned. So just a few housekeeping notes to kick us off. We've been asked by quite a lot of people whether this webinar is being recorded. It is, and it will be shared on the Global Health Network platform, including on the site that I've mentioned and that I'll introduce in more detail later. Please do use the chat box to introduce yourselves so that we have a sense of who's with us today and where you're based and potentially your roles. If you have any questions for the speakers that we should come back to in the question and answer sessions, please use the Q&A box, which is separate from the chat box, and we'll try to come to as many of these questions as we can. If we have a challenge with that, it might be that we don't manage to get to all of the questions. We'll carry on answering these questions through future discussions linked to the website. For any technical issues, please do message the Global Health team who are linked here. So we can stop sharing these slides. I'll come back and I'll introduce this website at the end of this session. So if we could perhaps go back to the outline of well, no, let's just leave it there. We had a speaker in our outline, Sarita from Nepal, who was going to go first, but Sarita's been having a few technical challenges and has only just joined her. So instead of starting with Sarita, can I suggest that we start with Frida Ngoa? And Frida is an emergency and critical care clinician based in Kilifi on the coast of Kenya. And Frida has 11 years of clinical experiences in different types of levels of hospital in rural and urban areas of Kenya. So Frida, thank you so much for sharing your experiences with us today, and over to you.
Thank you, Sassy. I would just want to say that I hope you can hear me.
Yes, very well.
So I just want to say thank you for this opportunity. One, I think we all owe it to the Almighty God that today we're even able to sit and actually discuss because of the pandemic, Corona that came, and it sparked a lot of emotions, I would say to me, COVID is more of an emotional disease than any other thing, in as much as it affects us mentally, physically, social-wise. It is all mixed up in emotions. So an emergency and critical clinician, as Sassy had started by saying, and I've had an experience here in Kenya for the last 10 months to be able to be the first clinician to work in a COVID isolation center in the Kilifi County Hospital, and currently as a team lead in that same field altogether. So in Kilifi, we had our first case in March 19th. That was about 10 months ago, and we had really vamped up. We had 6 cases, and after a while, that is in May, that's when we had the resurgence of cases, and now our numbers have been peaking through and through. Majority of the cases are symptomatic and well taken care of and back home, though with some of the complications. We have had reported a few mortalities with the same. And the challenges that we got basically from the initial time, as everyone would attest, this is a new disease, that there's not so much information and we're just using what we have to give the best that we can. And when the protocols were out for us, we were still a bit behind because in terms of equipment in the facilities, we were really not well planned out. But yes, social distance, masking, washing hands and sanitizing was a priority in it all. And I also think our initial cases in terms of equipment really did not vamp us up because they were basically asymptomatic cases and not the severe kind of COVID presentations. So lately we've been having the very sick, and that is also where it jogged our minds to be able just to give them quality care as they come to our facilities, because most of them would find that maybe they are symptomatic cases being handled at home, but now they had to be brought on board in the hospitals because they didn't continuum of care and they were symptomatic. So where we had equipment in terms of ventilators, being able to just put this patient on a ventilator, unfortunately, we had challenges because the technical know-how was really scarce in the use of these gadgets, as Kilifi County, in fact, with the surge of COVID, is where our critical care unit had not yet been well developed. We were just looking in for the inpatients that we're already having. The other challenge in terms of access to adequate equipment is that you'll find in Kilifi County, I have about only 4 critical care nurses, and being the only emergency and critical care clinician, it was a bit challenging now to say, let us give 100% to our very, very sick patients, because now the numbers are few. So in terms of continuum, it was still an issue in terms of health-related issues and also in terms of the human resource that we had. Some of the procurements we did in terms of equipment in using, especially in the critical care unit, you'd find we'd have the equipment, yes, but we are not able to sustain their procurement because either the consumables were not available at that given time because there was a high rise all over the country and all over the world to be able to just keep the patients on care. So you'll find numbers were increasing. So also maintaining our shortages came in with maintaining the services in terms of equipment in these patients. As we're all aware that in critical care, most of the equipment used are disposable. So it's one patient, one consumable. So you have to discard, you cannot share. We also had an issue with PPEs because yes, you're supposed to take care of the patients and yet you're running out of PPEs and you need to give care to this patient. but also basically the greatest challenge here was to my fellow health workers, everyone, because this COVID was more of a new disease. There was a lot said about it. So there was a lot of fear of unknown, and most of us who didn't want to indulge in something that is not known, something that you're not sure of. Socially, there was a lot of stigma. I had an experience where I'm working in the COVID facility and you have to go home, and your children are there, they can't play with other children because they're being told their mom is working in the COVID center. So stigma is really real from the hospital setting, from fellow health workers who would not want to actually associate more with people who are working in the COVID centers compared to those ones seeing just normal in and out patient facilities. It was really hard because you find these are people very close to you, you end up losing friends. And that's the time you really need someone to talk, because as we worked, you had to isolate yourself for 2 weeks before you're able to go home. And after the 2 weeks, actually, this is 2 weeks of working, so we'd work around the clock. Then you would have a 2-week time for quarantine as you wait for your results. You're not sure if you're going to turn COVID positive or COVID negative, and you really have to just get your hopes high and just tell yourself it's going to be okay, not knowing what tomorrow holds. So unfortunately, also in the line of work, I have had also fellow colleagues who got COVID. The stigma that comes with it is that you're called in, sometimes you'd be called in impromptu, like we're running short, numbers are rising and you're needed at work. So you get this call maybe late in the evening and you're being told just prepare yourself, tomorrow we need you to come and actually take care of patients. And you see emotionally someone gets disturbed. You're like, okay, why me? Because everyone was like, oh no, not me. So you're there and you're like, why me? Why should I go through the process? And you're being called late in the night, yet you have social adjustment you need to make, because if you have children or you have your spouse or even your house, and you have to tell them, I'll be away for the next 2 weeks, who's going to take care of the house, who's going to take care of your other businesses. So it became a challenge. Then there are also financial logistics to it, because now you're here and you know, if I walk out and walk in, I'll be able to supply what I need in the house for my family, for my relatives, and whoever is just I'm taking care of, or whoever is taking care of me. And here you have to go and just stick to that place for 2 weeks. So you don't know how the financial repercussions will be at the end of the day. Because in as much as you wanted to be given a compensation on the same, still you'd feel you're still worried. I think this is a point where most people didn't want maybe an extra allowance, because you're like, okay, an extra allowance, am I going to come out well or am I going to come out fine? Then there was this come because people felt like, okay, people are symptomatic, as many cases were, and they could survive the day. But then again, we had now this very sick cases where now you have to stay around the clock. And being an only emergency and critical care clinician, it was a bit tasking, because now when you have the very sick patients, you always have to come in and chip in. So in terms of labor, it was now really outweighing ones. There were really real burnouts, I would say. And you find when you're burnt out, sometimes you're not giving it all you have, but then you ask yourself, if I don't do it, who is going to do it? But we have our success stories out of these challenges we've gone through, because I think with time, we have not fully accepted that COVID is real and COVID is there. But we are at this point where someone can go and offer this service. Someone can go and do home-based care and actually prepare for themselves during this time. Now, I think also other challenge we had in terms of colleagues getting sick and taking care of them, you'll find our facilities were not well established. So now you can imagine we had experiences where we had colleagues getting sick and you have to come and actually put them with the patients, whether in different rooms, but in the same facility. So the stigma came in and it was a worry to our fellow colleagues, like, okay, I've worked in the same facility taking care of these patients that have got COVID, and today I have to be treated in the same area with them. So it was a bit of stigma within oneself and stigma from outside. You don't want to be associated. So we had one colleague who had to actually just keep to their room until the day he was discharged from the COVID center. But with time, at least we've been able to just take a place away from everyone. This is where the health workers are going to stay, and this is where we're going to have our patients take their stay. The other issue was, are we able to reach out to as many people as possible? Because the most difficult thing I think I've experienced in COVID is whereby fellow health workers also not acknowledging that COVID is real. Same group of people giving you stigma, whereas we're supposed to be having the knowledge, the know-how, so that we are empowered. So we set out to actually empower each and everyone and just make them understand that this disease is for everyone. It's unfortunate that when people also got the disease, it's when they actually came out to now also embrace the disease, because I don't want to say it's a blessing in this case, but it was a way at least of changing the mindsetting of most of the people. So at least now we are happy to say most people can come out and actually talk about COVID. But as it goes on, we want to see how best we can adapt with it, because I would attest that financially, people have really been broken. Emotionally, people have been broken, because even as colleagues, even as patients, you'd find the cases of gender-based violence have really gone high. So you're sick and you're on home-based care. We need to isolate you. Unfortunately, you have your spouse and there are issues, because now how do I stay in the same house in a different room and in another room? So a lot of violence came with that. And because of the stress issues, most families are not able to stay together most of the time because of finding resources here and there. So now it's a position where some have lost jobs. They have to stay together, and now you have to really try to fit in. So I think it was also a time, emotions, because people needed to learn each other better because of the situations that were around. The lockdowns, people not being able to move, people not being able to interact freely was a really big source. And also because the children were home, we have got a surge in numbers of teenage pregnancies, which is really unfortunate, though we thank God that also our government has allowed those young girls, young mothers who are pregnant, they can also go to school currently as they wait to deliver, so that there's just continuum of life. So I think the challenges that we have gone through are also the stepping stones on how we adjust as a community, as a country, and as I think as the world as a whole. So COVID, yes, is here, more emotional, but we always have a way out. And I think this is the time we really need to talk and really engage each other. Thank you.
Frida, thank you so much for sharing those experiences, which are so rich, and a mixture of the personal, the professional, the financial, the stigma, the fear of the disease itself, denial. I have a feeling that you could tell us about your experiences for a very long time, and there's a lot more we can learn from you, but so nice to hear about some of the positive actions that you've been able to take as well. Thank you so much. I mentioned that we will take questions after 3 people have a chance to talk. The next person that's going to share some experiences with us is Zila Zeze. Zila is the Liberia Country Program Manager for Redress. Redress is a large international research consortium looking at neglected and tropical diseases, health system strengthening, and COVID-19. And Zila, you have 15 years of experience working in the health system in Liberia. Welcome and thank you for being with us today.
Thank you very much. It is a pleasure. So hello, everybody. I'd like to use this 10 minutes to share my own personal experiences with Ebola in my country, but also to share with you findings from the research we have done on COVID-19 currently in my own country. So I'd like to focus primarily on 4 questions. One of them is which word I will use to best describe my COVID-19 experiences. Another is the context of COVID in my country. The third will be my experiences with Ebola and the lessons that I have learned. And that will be intertwined with my presentation on our current work at Redress, a research centered around COVID-19 learnings. So the word that I will use to describe COVID-19 in my own experience is the word tester. And I think COVID-19 is a test of global humanity, global community ownership and participation in health. It's a test of our adaptability, our health system resilience, but also our scientific efficiency and efficacy to handle and address emerging infectious diseases. So currently in Liberia, out of our 15 political subdivisions, only 5 of them are currently battling with COVID-19. And that is attributed a lot to lessons learned during our Ebola experiences that have been translated into actions in our COVID-19 response. So when COVID picked up, began in Liberia, we see that there was a real surge in cases around June, and then that leveled up. So my first experience with Ebola crisis, in 2014, Ebola hit Liberia. At the time, we had severely weakened health systems. We had come out of 14 years of civil crisis, so our health workers were inexperienced, we had insufficient resources, and everything was basically chaotic. When when Ebola stepped in, the health system was out of protective equipment, health workers were unskilled, and at the time, I was serving as a country manager of an American charity organization called MAP International. We were working with the health systems of Liberia to strengthen the health systems, but also to integrate neglected tropical diseases into the health system. So we're better positioned to help the health systems of Liberia. By May 14, I had made a major donation of protective equipment to the government, and you can see ministers of health and the press all covering that event. As a result, you can see health workers here donning PPEs and much more motivated to work. I was also engaged in community engagement and social mobilization. My organization trained community volunteers, and we work with them very closely to lead their own engagements in our communities. We're able to reach many households. We were supplying infrared thermometers, empowering community to lead their own fights. So of those who were able to train as community volunteers, they in turn went out in their own communities, educated households, erased the issues of myth within their own communities. Another area in which I worked was the area of watch. There was huge demand for water supplies at hospitals, communities, and schools. And on the left, you can see me on top of a Ebola treatment facility, along with colleagues from water missions doing water services repair. In this photo, I am walking on top of the roof because at this facility, all of the land space was utilized to accommodate patients by July and August. So the way to access the water facility was to walk on top of the roof. So we were taking all of the risks and putting ourselves at further risk. For this reason, my family distanced themselves from me, and I had to live by myself during the crisis because it was a hard decision to choose to serve the country in the midst of a disease that was leading to a very high death rate, or to back up and be with family. We were also putting out medications in the systems to address the issue of essential medicine and services. We were working with people of special needs, empowering people who have visual impairment to engage in fundraising activities. Another group of people I work closely with were the Ebola survivors. So as community took ownership of the response, we saw that there was a now decrease in the number of cases reporting to health facilities and increase in the number of persons surviving the diseases. So we're working, providing psychosocial support, religious support, counseling, food, clothing, and helping with rehabilitation. So we had to pay the hard price. I could talk a lot about personal experiences. For many nights, we had to sleep on both vehicles because we're avoiding houses, especially the fact that people knew us to be health workers. So at this time, I'd like now to speak of a research we have conducted within the health systems of Liberia. And we studied 24 national and county decision makers. And we covered the period of June and July while conducting the study. And the purpose of the study was to document learnings that can inform current response, but also help with strengthening health systems post-COVID-19. Our analysis were done against 8 key principles of the Foreign Commonwealth and Development Corporation of the UK, as well as the National Health Institute for Health Research. So my findings in summary will be presented against these 8 principles. So the first principle we have here, which comes from our findings, is that the principle of develop flexible pathway for medical supplies. So in Liberia, learnings from Ebola was utilized to improve response during COVID-19. So within Liberia, we saw a recommendation coming out being strengthening the health system, product management services, and supply chain. In Liberia, a second supply chain pathway was developed to allow for emergency supplies. And the lesson learned from the Liberian experience is that amidst COVID-19 and crisis, it is important to ensure that systems are in place to maintain continuous supplies to health workers, so the system in no point is out of supplies. A second principle is prioritize a list of essential services. At the initial phase of the COVID-19 in Liberia, Liberia experienced a slight decline in basic health services. But with lessons learned from the Ebola crisis that shut down the entire health system, Liberia as a country worked hard to maintain the provision of health services throughout the COVID-19 crisis, and has at no time has the health system collapsed, as no time has there been total stoppage of routine health services within the country. So another principle we have here is ensure continual provision of quality routine services. So in the presentation toward the left, we see that 2 major groups of people who are highly affected by COVID-19 in Liberia are pregnant women, and the other are children. But on the left, we can see that at the start of the disease, we see that the deliveries after the health facility rose a little bit in April, and afterwards it stabilized. It stabilized because services were maintained. There were a tracking system utilized to follow up with pregnant women in the communities and ensure that they were accessing services. Similarly, in April, we see a decline in measles vaccine uptake, but thereafter we see an appreciative increase in access to vaccine at the community level. And one of the strategies the Liberia used was to empower community volunteers to provide basic services within that community. And that means basically diagnosing and testing basic health conditions, including malaria and issues of illnesses that do affect children. The third principle here is build trust with local. The communities were empowered to lead their own fight against COVID-19, and communities are serving as gatekeepers. Active contact tracing is ongoing in the community, and community volunteers engaging communities are alleviating issues of misinformation, and improving trust within the health system. We have foster good communications at all levels of the system. With COVID-19 in Liberia, the adaptation of virtual meetings for supervision, for support, for training, continuous meetings have been utilized, and to an extent, the system is still being sustained as such. We have support, recognize, and encourage staff as one of the principles, and that is one of the things that Liberia is doing as a country. And then we have facilitate rapid flow to frontline providers and flexibility in the use. We have ensure fragile tracking of health information. So in Liberia, COVID-19 is part of the health information system, the surveillance system that is helping to track system information around COVID-19. We also have cultivate effective partnership and networks. Within Liberia, there is a decrease in the number of partnerships and donors because COVID is a global pandemic. But even as such, Liberia is seeking to gain ownership and lead its own fight against COVID-19 amidst meager resources. The ninth and last principle here is create structure and mechanism for advanced preparedness. This is not part of the FCDO principles, but it is a great learning that comes out of the Liberian experiences, because Liberia was able to create structures for surveillance, structure for contact tracing, for community engagement that were utilized during COVID-19. Liberia has been able to make headway against COVID-19. Thank you very much.
Thank you so much, Zila, for that that experience sharing, which I noticed that one of the comments, which you won't have seen, you were busy talking, was that, you know, the sharing so far has been really inspirational. I think really exciting to see about experiences and research contributing to principles and recommendations that I think would be echoed in many similar parts of the world. I think there's so much to learn from your experience.
Thank you.
Thank you. There are some questions coming in, which is great, and there's lots of asking whether recordings will be available of this session. Yes, they will be, and we'll share how you can access the recording of this entire session. Before we go to question time, could I just ask if Sarita, are you in a position to talk to us now? Are your IT issues sorted?
Yes, I guess.
Oh, wonderful. So, Sarita, it's a pleasure to have you with us. You're a research nurse based in Nepal, working for the Oxford University Clinical Research Unit. And I think you've had a lot of clinical experience before joining the research unit, and have experience of many different types of studies, including trials. So it's a real pleasure to have you with us. Welcome, and thank you for sharing your experiences.
Thank you for inviting and for giving me a chance to share my experience. Today I am going to share my personal experience relating with COVID-19, maybe, and how it has impacted me, and hopefully it will reflect the overall stories of health workers in Nepal. Maybe the scenario for other health workers may be worse than this, but I hope this will cover. Before sharing my experience with COVID, I will share a simple incident. Yesterday, I got a call from one of the relatives saying their family members has been admitted to hospital due to some medical condition, and she requested me to visit her in ward. And I went to see her in the ward. Actually, there is barely anything I can do while she is already under the medical supervision. Basically, I was expected to just make a visit, which I believe give them sense of care and security as their own person, and as a health staff is present if anything goes wrong. So I just listened to them and give some usual advice, which any person can give, even a non-medical person, maybe in much better way than I did. But those advice were given by their own person, non-person, which is also a health worker. and I see how grateful they were for my 5-minute visit. I feel very special, happy that people appreciate my work and skill. When people express how grateful they are to have a medical person surrounding them more than me, my work makes my parents happy. But yes, the scenario will not be always good. Was not good when I was tested positive for COVID-19. The case was completely opposite. It was in August when I get positive, August 2019, when I got positive. I get to know that by a phone call, which was made by one of the member of health and safety team of our unit. When I first heard the news that I got the positive, the only thing that came in my mind was the concern for my family, especially for my mother, who is like a patient of asthma and diabetic. Also, she gets very panicked very easily in simplest thing. And this time it was COVID. On top of that, it was with her daughter. And COVID at that time was a disease of death. The most news we were getting was people being infected and number of people dying. And only the, like usually the negative, bad reports we were getting. And I don't know why at that same call, I get emotional, and I was asking, what can I do next to protect my family? I even cried, not for myself, but yeah, the worry for my family and maybe some kind of guilt, where somewhere I believed I am putting my danger, putting my family in danger, and it is my response. It will be like responsible. I will be responsible for any that bad that may happen to them. I was in my room for whole time and was communicating with my family through calls. Up to this, I consider the condition was normal until when some unknown, I don't know who, but yes, they posted the list of positive people in our area, in our district, with details like name, age, address, even a phone number, which included my name. Immediately after that, people get to know about my report. They came into an action, but not in a positive way, I suppose. The discussion among the community people started. The way people look at us, my family is already different by then. Actually, I was the first person to be infected in our community. And at that time, the cases in our country was rising and everyone was alert and frightened. They were full of fear and conscious, especially because the news that was going around the social media, which were all mostly negative, and also not much has been discovered about COVID-19 by that time. I won't say that all the people were acting negatively in bad way, but there were some people with positive attitude also. But yes, few people within the community were overly active. They blocked the way to our community. Even some called the police, saying and in name of showing the concern to other members of community, like they are old aged people, children, diseased people. At least for them, the strict action should be taken so that disease doesn't spread. After that, police came in front of my home and warned us not to get out of house and pasted the poster saying restricted area, no permission until further notice. Yes, this kind of activities which are done by people and the official bodies and maybe with a positive intention of protecting and preventing people. But for us, those actions were more humiliating for us and more hurting. There were people saying I was irresponsible and should never come home while I was working in hospital in that situation. Other way also threatening, kind of, let's say, like threatening if any one of their family members were infected, then result won't be good for my family. And this was really like breaking me down. I thought if I stay separate or away from my home or community, it will be easy for my family, and also the kind of bad mouth can be minimized. So I decided to go to hospital to be in isolation room. So I informed my parents who were living next to my room, and I informed them that I'm going to hospital to stay in isolation. My parents were not happy to send me to isolation, as they were not here and worried that if I can get food on time, will there be anyone to talk with? Will I be taken care of? Even I was not sure about those things at that time. I convinced them, make them sure that I will be under the medical supervision. Special arrangement has been made for hospital staff, which I said just to comfort them. Uh, with all that, I transferred to isolation ward of hospital. I really don't want to make that image of crybabies of myself, but yes, every time I talk to my family, I cry. I do not know why, but I was very emotionally stable, emotionally unstable, and I was mentally disturbed. I even left my home for isolation, crying. In hospital, I shared a room with another staff who has also a similar kind of story like mine. Both of us were compelled to come to hospital, not because we need a medical attention or there were some kind of rule that we need to go to hospital if we're infected, no, but because of the way the society was treating the healthcare person, they were treating us. It was like we ran from the people because we have done some kind of scene, so we just ran. Most of the health personnel in the hospital had similar kind of stories, even worse than mine. After hearing the stories, I was kind of relieved that I was not the only who is facing this kind of attitude from the people. I was uh, like eventually when I was in isolation, eventually other member of my family were tested positive. Yes, firstly me, then my father, then my mother and my brother. I was kind of blaming myself. I was guilty inside that I made them infected. I transfer my disease, like I transfer disease to the community or to my family. They are being suffered by me. I was even shocked by over concern of people that even my elder sister who is married was demanded to do PCR test along with her, all the family members, including her husband, 9-year-old son, daughter, and in-laws who even don't live with us. And I think uh, is not necessary. Uh, like during my whole isolation days, I only wished for my health of my family. I recall how people used to ask for help in hospital-related matters. These people used to come in our home seeking medical, seek advice and appreciate me and my profession. And now that same people are cursing me because of my profession and my family. At that time, I agreed, like it's kind of immature, but yes, that I agreed with myself that I will never ever help or entertain any of the community people with my work or benefit any from my profession after this, for which I was completely wrong. I know it was wrong. Once everything was normal, people start to come and ask for help, and I help them as much as I can, because this is what my profession and family taught me. Definitely it took a very long time to be back in a normal situation. It was a difficult time. Me and my family were in isolation for more than months and had to face criticism even after the reports were negative, and as if they were treating us like even as if we will infect them even with the negative people. Yes, the situation is different now. People now make laugh that even they don't use the road by side of our house. How they used to pull the curtain to avoid the sight of us and ran down from a terrace when we were in our terrace. These activities makes us laugh now, but those were very, very painful at that time. Now, at this time, the situation is much more better in terms of understanding the disease, in terms of accepting the patient, a COVID patient, positive patients, which I believe because of awareness and knowledge among the people, and finding on COVID itself, the life are coming back to normal. People are kind of, but there is a fear that people are kind of ignoring the future possible worst scenario. Even people are avoiding to wear a mask, bothering to wear a mask these days, and they consider the COVID has been cured and it's very back to normal now, which is kind of fearing, like kind of give me a sense of fear also. With this, all the experience of a month, now at this time when I rethink of the event of that time, I see no good or bad people, or there was nothing completely wrong or right. Indeed, everyone is protecting themselves. They were doing their best from their side for themselves. And it is not because of hatred to some individual, but also because of fear and self-care. I think it's all because of knowledge and awareness, which was lacking, and which I think is improving by the time. And hopefully it will make the situation more good by the time. So thank you.
Sarita, thank you so much for sharing such a deeply personal and moving story. And it's really incredible to hear you talking positively now, looking back and not blaming it at a time that was obviously extremely difficult. Sarita, I don't know if we're able to just see your face briefly, if you're able to share your video, or whether the technical challenges don't allow it. But as you try to do that, just to mention that I think the stigma issues that you raised really resonate also with some of the experiences that Frida was sharing. And just another little comment to make is that these exciting lessons and principles that were shared from Liberia, I think Sally Theobald made a comment that some of these principles are resonating and being used to influence practice in Liverpool, in UK. So it's really good to hear that some of these positive experiences can begin to be shared around the world and have an impact more widely. We have some time for some questions now. There are 8 questions that have been posed. I'm just going to start off by asking the 3 speakers, perhaps just in the order that you spoke, just to speak very briefly, if possible, on one issue first, and that's what kind of psychosocial support you were offered in your institutions to deal with this really difficult, especially early in the pandemic, issues around stigma, fear, anxiety, etc. So I'll ask you each to speak one by one, or Frida, if you feel comfortable to go first, please go first. And then Zila. Thank you.
Thanks, Sassy. I think as COVID initially started, there was no much social support, psychosocial support, because you just had to walk in and you felt abandoned because you don't know who to communicate to, how you're going to handle your issues. But I want to appreciate that now people really gave it a heads up and knew that people are really disturbed as they work in the facilities. In as much as we are taking care of the patients, also the health workers needs it. So currently we are having sessions. They've actually brought in psychologists who have sessions, planned sessions like twice in a week, but you can always have them at your disposal at any time you need them, because they're there in the COVID facilities and also outside the COVID facilities. So I want to say it is true, initially no psychosocial support at all. You're abandoned because the thought of you're a health worker, you can take care of yourself. But we can appreciate that we are having that right now.
Thank you very much. Any additional comments from you, Zila, on that?
So at my institution, when COVID set in, the first thing we did was to develop guidelines to ensure that staff were supported fully throughout the epidemic and that no one was put at risk. As part of the guideline, we provided resources that staff will use to prevent themselves. We instituted all measures, including social distancing, permitting staff to work from home, and providing them resources to support them while at home, including support for electricity and so forth. We also provided environment in which we reduce workload on staff, ensuring that they were not overburdened even while they had to attend to their families and make sure that they were safe. As part of our interventions to ensure staff are safe, okay, and that they receive psychosocial support, we provided education, and we are relating to staff on a one-to-one basis, addressing issues that do pertain to them, not just with relations to, direct relations to COVID, but even indirect impact that COVID could have on individual persons. Thank you.
Thanks so much. So hearing about a multi-pronged approach really to those support processes. Thank you. Sarita, any comments on that yourself?
I think the organizational support, the team has given the much psychological support in my case. Despite the community people, but yes, the whole health workers and my team has given very much support from the very beginning, and also has given the most. They have given resources now, which was not before, but psychological support was from very beginning. And they have, like other people, there has been change in guidelines. And yes, we do have a lot of resources, kind of PPE is provided now. And we do have, also I did a work from home for months, which was, yes, for me to be secure, and I was not confident, and I was mentally not prepared to come to hospital, and I don't want to get reinfected. Kind of fear was instilled in me. So that kind of support was provided, and I appreciate that very much.
Thank you. So it sounds like across all of you, a mixture of increasingly over a time, potentially a bit more formal support that was being offered, but not much at the beginning, more informal amongst colleagues and friends, where those friendships were able to be maintained. And also some time out, it sounds like, Sarita, was essential, given what you were going through. Thank you. I think what we should do, perhaps, rather than take more questions at the moment, because there are quite a few more questions, which is great. And I just wanted to hear from the last two sets of speakers so that we can have a little bit more time at the end to go back and include all of the speakers in the discussion session. So could I introduce next Anna Halland and Isra Hassan, who are going to talk to us together. Anna Halland is a social scientist and a trainer who I've worked with for many years, based at the University of Oslo. And Isra Hassan is a consultant with the University College of London and currently a frontline carer in an intensive care ward herself in UK. So very happy to hear from you both, and thank you for sharing your experiences, including on setting up training and support processes for staff facing emotional challenges.
Okay, so Sassy, thank you very much for that introduction. Can you hear me? Am I on?
Yes, we can hear you really well, and we can see your slides nicely.
Yeah, okay, very good. So it's very moving to hear how you are all working in the field in very difficult situations. And I think the headline of everybody is really emotions, dealing with emotions, dealing with stigma, trying to take care of yourselves in very difficult situations. And this is what a model that we have been working with now for the last 15 years has been developed to train you in how to take better care of. I would also like to just acknowledge that Rita Sopiene is here from Lithuania, and she was the original among the original group that started this work in Lithuania in 2006. So wonderful that you're here, Rita. I was asked to speak about my own COVID experience as part of this presentation. And I was a patient in a hospital in Oslo this spring. And what I experienced was that the staff was very impersonal. They were professional. They were full of fear. I looked at most of them. And this fear was very contagious. So I felt very, very uncomfortable in hospital. And I really wanted to get out fast. Situation for them was very, very difficult at that time, and still is. Right now, my boyfriend is in hospital. I haven't been able to see him for 1 month because we are simply not allowed to get in to the hospital. Now, so that is, I have also been working with the students to try and teach students how to communicate. And before the communications training, in spring, their report showed that there was very much insecurity and fear. They were living in families, in small flats, many of them from multicultural backgrounds. They were inside, there was a lot of conflicts. And also with patients that they worked there, they said there was a lot of conflicts. It was very difficult. Many friends were in denial. And there was a lot of fear, and they described emotional exhaustion. So in this situation, I would like to just take you very briefly to a model of communication training. And what we have done here is to introduce a culture of reflection in hierarchical cultures, like in the national cultures as well as in medical cultures are very hierarchical. So how do you communicate well in those and taking care of your own emotions as well as those of others? The model that you can read more about on the website is called the iCare Holland model, and it's about communicating with awareness and emotional competence. The last 10 years, I have been working together with Moana on the picture here, whom you will hear from next. And the model has been developed and conceptualized in collaboration with doctors and nurses from 9 countries. And all of them are saying that the main thing they learn is, the most important thing they learn is about emotions. The training takes time because changing habits takes time. And it goes in several stages that you can also read about, but it's self-awareness, it's training, more self-awareness and more training. Briefly about the main things that we teach in this model. The key is to become aware. When you become aware of really how you communicate, how you relate to emotions, you observe really in action when you're doing it and the effect of your communication, then something happens to you. Many people get a shock, an insight into, oh, is this how the reaction to my communication is from others? Do they really get hurt? What happens when I communicate in my normal way? Here is something I really need to change. This picture is also from Lithuania, from 2006, from the first training we had. So some of the changes that are happening are that for example, that people think before they speak. They hold back from reacting. They don't react automatically anymore. And this is the key thing that is needing to change. So when they see that they hurt other people, when they see that they delight other people, they say, aha, here is something that I need to change, or I need to practice more consciously. And they take responsibility to communicate with awareness and emotional competence. So this is a huge change. And it means that this training is very easy, actually, in many ways, because people want it. And the aim is to expand their choice of communication strategies and how to use them with awareness and good effect. Because when you communicate with awareness of the emotions, you communicate well. Authentically, using appreciation and empathic understanding. This is as important for health providers as it is for researchers. So some learning from this, from having worked with this model, from training and research with the iCare model, is that the main need, as I have said, is to recognize and manage emotions with awareness, empathy, and compassion, and to use emotional competence. So with this, let me turn over to Isra, whom I worked with in Cardiff in 2016 and 17, to train them in using this model. And Isra, over to you.
Thanks, Anna. Thank you everyone for inviting me here today. And I'm just seeing the chat, there's truly a global representation of everyone. So a bit about my background. So this has been an unusual year for everyone, but in terms of my career, I've transitioned from a registrar to a consultant, and I've not picked the best time to do so. So my background is an anaesthetist. I'm working currently in UCLH in London, and we are in our second surge. So at the moment, currently, we have over 90 intubated patients in intensive care. Just to put context into this picture, normally pre-COVID, we have about 34 beds, intensive care beds. So we have gone our capacity, and which means that people are having to be redeployed, including myself, and now I'm on the consultant intensive care rota. So a change in role. It was really interesting to hear speakers from this morning. We shared similar challenges, and I feel very privileged that back 5 years ago, I worked with Anna and I did a 6-month workshop in iCare. And as medical professionals, we do a lot of courses, mainly tick boxes to complete the CV. But I genuinely feel this is one of the most important workshops that I attended. It provided me with a skill set that has been invaluable, both professional and personal. And I feel that's given me a good foundation to deal with COVID. Challenges is, I think we've got the same problems worldwide. It's unpredictable disease. It's causing massive morale within the healthcare professionals. Patients are feeling isolated, relatives feel frustrated, and there's a definitely sense of lack of trust in what we're doing because it's not transparent, because we're having to not include them in our decision makings all the time. And I feel that this is unprecedented times, but as Frida mentioned, we have had opportunities, or there have been positive things that have come out of COVID that I've seen particularly, and having more of awareness through Anna's teaching. I recognise when things are going well, so appreciation. I mean, we often, it's a thankless job, but I don't know if you know that in the news, every Thursday for the first wave, there was the national clapping. Having that appreciation, that thank you went a huge way. Donation from restaurants with food. So first time we've had hot food in work, or regular free food. Normally there's no food in work. And also donations for cutlery, cups, sofas, rest areas, which again, we never had pre-COVID. I also saw firsthand excellent leadership. So where my consultants, CDs were on the shop floor, they were with us and leading by example. And I think that was something that was exemplary. They weren't asking anything different from us that they weren't doing themselves. And I noticed in the chat people want to know how we cope and how we translate to our patients and relatives. And I think it's really important to first and foremost have a personal awareness, because you can't deliver care if you're not in a good place. And I think through this teaching, that's become more paramount to me, that in order for me to be a good clinician, I need to make sure I'm looking after myself. And there's going to be periods where I'm vulnerable, where I'm tired, where I'm hungry, and that's going to affect my communication skills. But having that awareness now that I'm in maybe potentially a vulnerable place, do I need to go for a cup of tea? Have I got the opportunity? Do I need to have a bit more patience because I am tired or hungry or I'm feeling overwhelmed? And do I need to listen more without speaking, without, I need to think before I speak? And I think with a lot of us, we need something to focus on and look forward to. And often with my friends and my colleagues, it's having a holiday. And with COVID, that's not been possible. But I think it's really important to have something to look forward to. It might not be in a month, it might be this week. Is there a good day, a nice day of the weather where I can go for a walk? Having that something to look forward to, for me, has been really, really important, because otherwise it just feels a bit helpless. And I think you do need those little glimpses of hope. And then lastly, I just want to talk about the other aspect of looking after patients, relatives, colleagues and juniors. And I haven't got time to go into it detail, but what I've learned from this training is that our normal ways of coping, of giving good clinical care when things are pretty horrendous, is holding a patient's hand. And we can't do that. Or giving my nurse in charge a hug. I can't do that. I can't see them. I can't smile. And these are, I found, quite hard. But there are ways to get around it. Listening to them, listening to relatives. And what we do very well at UCLH is that we have daily family liaison updates with the nurse, with the medics, and we have a family liaison team that will keep in contact with the patient's relatives every day. So it makes those decisions and those communications where patients aren't improving a little bit more, not easier, but what I'm trying to say is that they trust you more because they've seen your face. They know the story. They know that you've been trying your best and now things aren't going the way, but they have trust in you. And I think those communication skills are essential in order to cope through this pandemic. And so that's what I just wanted to say today.
Thanks very much, Isra. Can I just have 2 minutes to finish up, Sassy? Fine. Thank you very much, Isra, for those experiences. And when I spoke with you yesterday, you had just come off 72 hours shift, and I thought, wow, this is really tough times. Let me just wrap up by showing you what some of the students are saying that they are doing differently after they have been learning these skills. They are communicating with awareness, and mostly, as Isra was also saying, listening is very powerful. Recognizing, stepping back from automatic reactions, recognize and understand the fear in themselves and in others, and not let it infect them themselves. Listen and empathize and comfort and create safety. That's what they say, it makes a difference. And one of them put it this way: I think about what others maybe feel and think that they have their reasons to have their ideas and to feel and act like they do. This stops my judgment and enables me to listen and empathize. So being able to put yourself in the other person's shoes and having the awareness to do that makes a huge difference. Finally, about well-being during the COVID times, emotional nurturing. For me, it's my cats and it's nature. And other people are saying it's time for reflection, exercise, natural beauty, and the friends and family, like Isra was also saying. Finally, the changes we have seen in 9 countries by using this model is that the participants are reporting improved respect for patients and colleagues, strengthened awareness, recognize emotions, as we've been talking about here. They stop blaming patients. They take responsibility for communicating well. They give better care there's fewer conflicts, reduced stress and burnout, and improved job satisfaction. So using this model to get those skills is what we have been doing and what seems to work. The model will be here fully on this website very soon, but so far there is quite a lot already. Thank you very much.
Thank you so much to both of you for introducing and sharing some information on that model, but as you say, there's lots more to learn and available on the website, and also reminding us about the importance of emotional nurturing. And Isra, thanks for sharing your experiences. And I mean, I think in the discussion, it would be great to come back to hear from others as well about what the public have been doing to support them in their frontline services. So I don't know about any clapping in Nepal or Kenya or Liberia, but I'm sure there are other ways that communities have been showing support, you know, as another layer to some of the stigma that's also been faced by everybody. So I look forward to coming back to that. We're just going to hear next and finally from Mwana Mvua-Boga, who's a nurse manager and the lead trainer at the KEMRI-Wellcome Trust Research Program in Kenya. And as was already introduced by Anna, Mwana has worked a lot with Anna and with the model and has been able to apply a lot of that learning expertise and experiences in COVID. So over to you, Mwana.
Thank you, Sassy. I've been waiting patiently. It's been a long wait, but finally we are here. So let me share my screen. Okay, so can you hear me? So I just want to share my own experience in using the eye care training model to support patients and colleagues during this pandemic. And as you can see on the screen, that quote there, that the work stress is way too much. And if you take everything in, you will get really frustrated. So this is a quote from one of the nurses that have been supporting. So I just want to share my recent experience regarding handling patients with COVID. So currently, our health workers are on strike in Kenya. So most of the public hospitals are closed, and no isolation units, and we don't know where patients are going, especially the poor who can't afford. So we have a small research unit, as you can see on your screen, that is serving our pediatric population at our region. And we've been open, we don't go on strike. So it's been very heavy for us for the last 2 months, handling a very heavy workload. So last week, I had a 6-month-old baby who came in with diarrhea and vomiting, with malnutrition, and then had some difficulty in breathing. So we did a COVID test for surveillance as our routine surveillance. And 2 days later, the test came positive. So as you can see, we were nursing that patient in an open ward. So when the results were relayed to me by the consultant, to be honest, I felt a wave of fear because I had handled this patient for an entire shift. So I got really worried, but again, I just composed myself and said, okay, I've been on my mask throughout, I've been sanitizing my hands, I've been washing my hands. Do I really need to get this worried? So I composed myself. But again, it was a very tense moment for everybody because this patient had interacted. I mean, the mother and the patient had interacted with many of the staff, from the housekeeping to the consultant. So it wasn't an easy task. So the reaction I got from my staff was like, now what? Where do we take this patient? Where can we take this patient? I mean, what happens? So I recognized their own fears and appreciated them for the hard work that they are doing to support the children. But again, I acknowledged to them that we have been on our mask, we have been using our hand sanitizers. So I don't think we need to panic that much. So I reassured them, and then I told them now that we can't take this patient anywhere because the results came in the evening. We just draw the curtains and isolated the mother at the far end of the ward. But I also encourage my staff that we need to handle the mother with empathy and not to stigmatize her. So the following morning when I came, I sat down with the mother, talked to her, reassured her that we are here, we'll take care of you. to the best we can. So we evaluated the patient that morning, and it was much stable to go home. So we discharged them on home-based care, and the child has been doing well. I called the mother this morning, and she told me that the child is doing very well. So those are some of the skills that I train the health workers using the eye care model. And to reflect on my own experience here, the skills I used is I was aware of my own fears, and I stepped back from reacting to the situation and say, oh, you know, we need to close the ward, we need to fumigate, we need to do this. And I also recognized the mother's fears and handled her with empathy and concern, because she was also quite really afraid. And I appreciated my staff for the hard work, because they have been working hard for the last 3 months. The workload is way too high, and listened to their fears, reassured them of their own safety, and then told them, let's just listen to our bodies. If you feel anything different, just let us know and see how best we can support you. So during this pandemic, I was running this training with a group of newborn care nurses across the country. But when COVID happened, we put all our activities to a halt because I could not travel. But I kept in touch with them. We have a WhatsApp group, so I could send a message, how are you doing? How is everything? And nobody would answer those chats. So I said, let me just call them and find out how they are. And when I called them, all of them, they said, we are feeling overwhelmed, we are feeling burnt out. So after calling all of them, the 16 of them, then we agreed with them that let's come together and share our experiences and support each other and see how are we coping in this situation. So we had online psychosocial sessions. And so I managed to have three discussions with different groups, and the discussions were lasting 2 hours. So during those discussions, the nurses shared so many challenges, and all of them said that they were highly emotionally exhausted. We ran a small burnout poll just before the discussion, and they had so many reasons to how they were feeling. So the workload, the long working hours because of the curfew restrictions, increased the number of infections and the mortality in the units, and that is a picture one of the nurses shared during the discussion, that the workload is way too high. So there was also a shortage of staff, as the nurses had been removed from the hospitals to work in the isolation units without any replacement. And the shortage of PPE was a great concern. And some of them said they were given a surgical mask to wear for 3 days before they can get a new one. And that was really challenging for them. And then there was also lack of COVID-19 testing facilities for staff. One of the nurses shared that when you get flu-like symptoms, you just go home and quarantine yourself. And once you get better, you come back to work. And at that time also, there was no psychosocial support for the staff. So that's why we agreed to come together and support one another. But later things improved with regards to psychosocial support. So the list of challenges was way too heavy, and I could really feel the way they were, how emotionally exhausted they were. So in that discussion, we asked each other, so how are we managing the situation? How are we coping, so that we can share strategies and see how we can help each other? So most of them, they said that awareness was very key. Just being aware of the situation and what you can do and what you cannot. And this is an experience an example from one of the nurses saying that being aware of the situation, seeing what I can do, what I cannot realize, what I cannot do, has really helped in dealing with the current situation. And then appreciating each other, working as a team, as Isra has said. Support from management was also very key. They said the units where they had support from their managers, they felt that was really motivating for them. And then celebrating small wins and gains and engaging in self-care activities. And I just want to talk about the support from management. Myself being a manager, I think this is something very important, because I had 3 of my staff who tested positive for COVID, and 1 was hospitalized and 2, they were on home-based care. So I just put myself into their shoes and imagining how they were feeling. So I had to call them just to see how they are doing. How are you? How are the children? How is everybody at the family? And that was really supportive for them. And when they came back to the team, back from the isolation, we encouraged them to share their experiences. How was it like for you in the isolation? So that at least we demystify the stigma, and that really helped in coping. And then the other strategy that we also had is, among the staff who tested positive, they had a WhatsApp group, and they could communicate and share and support one another. So also, just to share our own a small win that really motivated us, because that's one of the strategies that the nurses said, that celebrating small wins really made a difference during this time. So when COVID hit, we had quadruplets, extreme low birth weight below 1 kilo and 0.9 kilos. And these babies were with us for 1.5 months. So when they were ready to go home, the family had no home. The house had been brought down by rains. So we called for support from well-wishers who responded so well to support the family. They built a house for them. And finally, when they were ready to go home, we escorted the mother with the baby to the village. And it was such a very nice moment that really demystified our fears around COVID, and say that even within COVID, there are things that can really motivate us. So celebrating small wins within this period was also very crucial in terms of coping. So these babies are now 9 months and they are doing very well. So in conclusion, what I'm saying is during this period, I mean, the emotional exhaustion and burnout has been real, and it's like it's been an additional layer to an already really burnt out health worker. But what I'm saying is, during crisis, communicating with awareness, using appreciation, showing compassion is very important. And health workers are not trained on emotional competence. They lack support systems. But we see using the eye-care model enables providers to develop that self-awareness on how they're communicating and managing emotions. And these are essential skills in well-being. And from my own experience, just being aware of how I'm feeling, as it puts me a notch higher to take constructive steps in terms of managing myself. So that's the training that we have been running and continue to run it to empower our health workers to relate well with patients and also be able to manage the many emotional challenges that they are facing. Okay, Sassy.
Thank you so much, Mona, for sharing such rich experiences. And I think you'll see as you look at the chat that people are feeding back as well, being inspired by what you've managed in really challenging contexts. And I think hearing you talk, you're not necessarily talking about big new funding or huge numbers of new staff. You're talking about the challenges and the realities in front of you, and using some of the skills and strategies that you've learned through the eye care model training and in your broader experience to support your team and yourself. I think that's really inspiring. I think the other thing that is a really nice an important reminder that everybody's dealing with COVID on top of many other issues that continue to be there and are sometimes even made worse in terms of lots of other health problems happening in context, and issues like a strike, which obviously brings huge challenges in itself and is linked in some ways to COVID-19. But these are really complex realities that everybody's having to deal with. We've taken longer in hearing everyone's voices than we had expected, but it's just been so rich to do that. I think everyone here will agree that it's been wonderful to hear everybody's different inputs and perspectives. We've heard a lot about the emotional impact and the mental health challenges and possibilities and risks of burnout among health workers, and the importance of having trusting relationships with communities and patients. I'm going to come back to just ask some question, just one question of everybody, to just give one last word on any additional things that they would like to suggest in terms of strategies to minimize or reduce the possibility of burnout. I think we've heard a lot from these last speakers on that, but if anybody wants to add anything else into there. Meanwhile, could I just have my slides back that just introduce the webinar, please? And in those slides will just help us share with you all where we hope we can continue sharing experiences, sharing resources, and discussions on not only COVID-19, but on the dilemmas, the experiences, the innovations that frontline staff encounter in their everyday lives. So this, if you go back 2 slides, okay, yeah, so this is the Connect website. It's on the wider Global Health Network set of sites. It's an opportunity to connect people working at the front line. Forward 2 slides, please. Thank you. So this is a site where we can share blogs, discussions, and a whole range of different resources. So you have already been introduced to the eye care manual. You'll have an opportunity to see lots of elements of that manual that you will be able to engage with in your work and be inspired by. There are also other types of resources, and we'll continue to organize webinars and workshops and hear from many other voices from the front line. So we'd love to share your own resources. Please do email this email here, and we can hopefully keep the conversation going and continue to share ideas and support processes. So many of you might need to leave now, given the time, but if there are any last reflections from the speakers on strategies to prevent burnout and to support emotional management, that would be really appreciated. Thank you.
Can I just say very briefly, Sassy, that the main thing is to recognize that you cannot take well care of others if you don't take care of yourself.
Thank you very much. That's a really nice thought.
You know, just taking care of yourself is so difficult for many people, but please, 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 please do it.
Thank you. Any other last thoughts?
Yeah. Yes, Sassy. Frida wants to go first.
It's okay, Mona can go on.
Yeah, I think from my own perspective as a manager, being very aware of your staff is also very important, because when you see them struggling, then it enables you to approach them and talk to them and see how best you can help. So one thing that we have in our program is counseling services. So through the occupational health and safety department, we have access to a counselor at any time that a staff needs. So I think those services are very essential, not just during this COVID period, but they should be available within the health care facilities.
Thank you, Mona. Frida? Frida, are you with us? I think she's got stuck. Anybody else want to make a comment? A last comment?
So thank you. So on the issue of burnout, if you observed my presentations, you saw how very slim I was during the Ebola crisis. So I do understand the effect that burnout can have on health workers. But I think one of the things that contributes to the extent of burnout we do face is that we become very empathetic about the work that we do. So we tend to not find time for ourselves. So I think one of the things we need to do as health workers is to understand that we have to attend to ourselves and to our families ourselves as well. I think we need to emphasize the need of setting some time aside for ourselves, keeping our minds off work for some moment. And I think that can help with burnout issues.
Thank you so much. Frida, you look like you're moving again on our screens.
Okay, so sorry, I just dropped off, but I would want to say it is good to just, one, teamwork is key. Don't work as an island. Secondly, just use the available resources and the skills you have. Just know you can only do much, and there's nothing wrong in not being able to supersede what you have. Just give your best at any given time and know your limits, and just be self-aware. Keep on smiling.
Thank you very much. Isra?
Similar, really. So look for the small wins, and they will help definitely. And just the key of good communication, being authentic. You're not going to have all the solutions, but as long as you're genuine and authentic, it goes a long way for your colleagues and your relatives. And I think that's the key.
Thank you. Very wise. Sarita, do you have any last comments?
Yeah, I think it's very important to verbalize like your needs and what you're experiencing. I think that helps a lot. In terms of expressing yourself, you're letting your emotions out, and also until and unless you speak, maybe the management also will not cannot do anything because you are working in a certain area, and maybe the person who can help will not know the need. So I think you should speak up when it's necessary.
Thank you so much. Yes, very, very crucial and sometimes challenging to do, but so important. I would just like to thank all of the attendees and especially all of the panelists for sharing such moving and inspiring stories from all over the world. And we really value you taking the time and teaching us and sharing with us in different ways. And we look forward to taking this conversation forwards and continuing to share your own resources and others on the website and in other locations. So with huge thanks to you all.
Sassy, if I could say something.
Sure.
I just want, just before we leave, everyone should know that mental health is not for the sick people, but we all need it. So if you have a counselor somewhere, a psychologist somewhere, just reach out and talk, and you'll find out you have issues that they can really work out. It's only not for the patients. We all need it at one point. We are all humans. We have emotions. Thank you.
Thank you, Frida. Great note to leave us all on. Many thanks to you all.
And many thanks to you.
Thank you. Bye.
Thank you and bye.